Next up, we have a panel discussion with the Global Brain Health Institute, and Karen Meenan has kindly offered to chair this session. So I'll turn it over to you, Karen.
Thanks so much, Kim. And yes, delighted to chair this session with my GBHI colleagues. I'm so delighted to see everybody here again today. So I'm going to give you a little whistle-stop tour, and then I'm going to introduce our first speaker, and that's Tomás León from Chile. So we'll have, first of all, Tomás, who's going to speak about his project. And then we will have Gráinne, who is our cellist, our musician, social entrepreneur who is working arts in dementia care. Then we'll have Luciano, who is joining us from Brazil. And then Hanan, who is joining us from Jordan. She's a physiotherapist in Jordan. And we're going to finish off with Dr. Sarah Fox, who is in Greater Manchester. And her project is all about PPV, patient person voice. So over to you, Tomás. Maybe you would introduce yourself, tell us about your work, and are you going to use slides, Tomás?
Hi, Karen, thank you. No, I'm not going to use slides. My name is Tomás León. I'm a psychiatrist from Chile. Sorry about the mask, but I'm in the hospital, so it's required. And I'm going to talk to you about my project. As you may know, the number of people living with dementia is increasing every year. And the number of people, specialists, suited to treat dementia are not increasing as much. So in our country here in Chile, but probably in the whole world, the number of people with dementia surpass the number of people training to treat them by a large number. And the answer for that is not train more psychiatrists or neurologist specialists in dementia, but rather to train the people who are more close to the treatment of people living with dementia and their caregivers, and that's primary care. Primary care in most countries are responsible of over the 80% of all the population, including and especially the people living with dementia, because they are often more poor due to the dementia, and they're required to be in the public system of health. And the problem that we have, at least here in Chile, and I know that is common in all countries, is that the people working in primary care, both doctors and non-medical professionals, they are not trained in dementia. So what we are going to try to do is to create a training course for dementia, but not only a training course that is going to be in person, because often that is not suitable for the training for the teams, because they don't have the time to go to a certain place to receive an online a course. So what we're trying to do is create an online platform in which you can access anytime and get tailored information for your needs. Meaning that if you're a doctor in primary care and you need information about diagnosis, you go to the diagnosis section and get that information quick. If you need treatment information, to do the same. But also, if you're a non-medical professional, for example, a physical therapist, a social worker, or a psychologist, you can also go to that section and get information tailored for you. The first step is to raise information from the primary care teams, and we are doing that right now, on what they need, what they feel that is important for them about dementia. Because often these courses come from the specialists and they're not suited for the reality of primary care. Then we're going to create the course. And the long-term goal is to expand this not just to Chile, but the whole Latin America, creating a Latin American online platform with information about dementia for professionals, for caregivers, and also for patients.
No, that's fantastic, Tomás. Thank you so much. And I know you're in hospital right now, so we're going to let you go back to your patients. Just for the people who have joined us for Engaging Dementia Conference, there is a daylight savings time in Chile, which has changed time since we organized this. So Tomás has just literally run out from clinic and back into again. Tomás, thanks so much for joining us today. We'll say goodbye to you.
Goodbye.
All right, cheers, bye-bye. So Gráinne, you're up next. So Gráinne, You're very welcome to engage in dementia today. Thanks so much for joining us. And maybe you can share your slides and tell us a little bit about the work that you're doing in your pilot project.
I will do. Thank you very much for having me. I'm delighted to be here. I suppose the presence of arts in healthcare settings is not a recent development. For many hundreds of years, portraits and sculptures have adorned the corridors and waiting rooms. I suppose it brings about a sense of wellness. The ancient Greeks and Florence Nightingale believed that a person's environment influenced their sense of wellness and well-being. So I was delighted and honoured in 2020 to have been awarded the opportunity to become a Global Brain Health Institute Atlantic Fellow, and was excited about collaborating in expanding interventions by sharing knowledge and learning from and with a powerful mix of fellows from different countries, disciplines, professions and backgrounds with different skills and perspectives. As a GBHI fellow, I had the opportunity to apply for competitively awarded funding for a pilot project, which if successful would be supported by the Global Brain Health Institute, the Alzheimer's Association and Alzheimer's Society UK. I am delighted to share with you that I've just recently heard that the project has been awarded funding. So I will share a little bit about this project with you today, as well as two recently developed project partnerships between music, bringing music into nursing homes and community hospitals in Ireland. Okay, to start with, I'll give you some background to this work and my project. Aside from being a GBHI fellow, I'm also the founder and artistic director of Kids Classics, a non-profit organisation that designs, manages and delivers professional music projects and programmes in healthcare settings around Ireland. The name belies the breadth of work we do. We also train musicians, and as part of a Kids Classics programme partnership with the National Concert Hall, we've delivered introductory music and healthcare workshops in schools of nursing and midwifery at TCD, UCD, DCU and DKIT. All of our programmes have had to be COVID reimagined, as you can imagine, and we were delighted, despite COVID, to be able to develop two new projects in Meath and Limerick. The first one I'll tell you about is called Musicians on Call, a project which involves professionally trained healthcare musicians working to connect music making opportunities to residents and healthcare staff in settings in Limerick, offering live and virtual visit options and a set of taster sessions in Clare and North Tipperary to an additional 7 healthcare settings. This project is led by Limerick City and County Council in collaboration with Age Friendly Limerick and Healthy Limerick, supported by Creative Ireland and developed in a partnership with Kids Classics and the HSE. The Musicians on Call project aims to bring high quality live music to vulnerable older members of our communities living in nursing homes and their carers in a way that is more than an outside-in audio live broadcast, driven by equity of experience for all and a shared social experience. The second project, which we were delighted to run in the last 6 months, is called Tea Chats and Tunes. It evolved to respond to the need to find new ways of connecting some of the most vulnerable members of our communities isolating in nursing homes with their families at home and abroad. In many cases, due to the challenge of technology or the health capacity of a resident, two-way conversations are limiting or challenging for family members, as well as for the staff who have to facilitate them. Tea Chats and Tunes changes this dynamic and removes the pressure of the situation through creating a shared opportunity to engage in a live and bespoke cultural experience in a safe way that accommodates for health issues such as dementia. Tea Chats and Tunes is another project partnership, this time with Meath County Council Arts Office and supported by funding from Creative Ireland, the Arts Council and the Age Friendly Meath Keep Well Fund, delivered to 90 nursing homes in County Meath. This leads me to my GBHI fellow journey and making the case for music in dementia care. The fellowship offered me the opportunity and time to explore a few areas of interest, including what a quality and best practice framework for music in healthcare might look like, how live music could improve quality of life for people living with dementia, and the possibilities around developing partnerships with researchers, clinicians, policy influencers, healthcare settings, and dementia care providers. What I learned is that currently there is limited cross-sectoral partnerships or joint thinking in policy, and that we do have evidence of the engagement in the arts and its impact on well-being. But the questions that still stand for me are, who is reading the evidence? And would gathering more evidence have any impact on making the case for supporting music in dementia care? I see my role in this project as that of an architect, to support building bridges between stakeholders and to grow the understanding of the potential of clinical creative partnerships in dementia care models, the healthcare environment, and in the quality of lives lived. So for my project aims, there are a few, and they're ambitious. to identify and map cross-sector partners with an interest in supporting the development of high-quality music and cultural engagements in healthcare settings, to achieve stakeholder input and consolidate views and knowledge through a series of interdisciplinary roundtable discussions, to produce a document to foster long-term strategic partners for best practice in music and dementia, and to build a practice-based network of key leaders who are engaged to continue to advocate at all levels for clinical creative partnerships in healthcare settings and in particular in dementia care. This pilot is intended to be an educational and development project to build on over 12 years of my experience in the delivery of live music in healthcare settings, to examine outcomes, embed partnership opportunities across healthcare disciplines and care models, and scale the positive impacts of music and health practice in Ireland to support the lives of people living with dementia. As a senior fellow, my goals are to support cross-disciplinary and cross-sectoral partnerships and practice of discussing the value of arts in health interventions, to share an understanding of the training and artist supports required when working in healthcare settings and alongside people living with dementia, to support a strong case for high-quality cultural activity as an integral part of care for people living with dementia, and to support future research and the potential of co-commissioning of evaluation projects and programs in hospitals and nursing homes. So I leave a question with you all here today. Is it not time to recognise the role that the arts can play on the positive impact to well-being, brain health and quality of life for all in our society, including the lives of people living with dementia? I just want to thank you all for giving me the time to share this with you. I look forward to sharing the findings of the pilot project with you when it's completed. And I'm delighted now to have the opportunity to hand you over to one of my colleagues and GBHI Senior Fellows, Neuropsychologist Luciano Mariano, and his presentation on why do behavioural changes matter. Thank you.
Thank you, Gráinne. Thank you all for having me this morning. Actually, I'm sorry, this morning in Brazil, but this afternoon in Ireland. So it is a great honor to be here today, and I'm going to talk to you about why behavioral changes matter and why this is relevant for us to talk and to think when we are dealing with patients and when we are considering the investigations we are doing. So I am a neuropsychologist from Brazil, and these are my backgrounds and associations here in Brazil with some research groups, and I am also delighted to be part of the Global Brain Health Institute and to share some backgrounds for the research and the pilot I am planning to develop. I am going to make a presentation about some theoretical and practical points which are relevant, and I am delighted to have and answer questions in the Q&A session regarding the pilot I am going to develop. So I have nothing to disclose for this presentation. Unlike Gráinne, I am going to make a presentation with scientific and boring stuff, which is kind of my fate. When I talk, I always talk after Gráinne, and she's always fascinating, and I have to talk about the science and boring stuff. So to get it started, if we think about dementia throughout time, we are going to see that it has been conceptualized mainly as a cognitive condition. So if you ask someone about what dementia is, the probability is that people will say that dementia affects memory, that dementia changes the way people think and reason, and it's hardly that someone is going to point the behavioral aspects of dementia. But now we understand that dementia affects behavior. And in fact, we have this behavioral psychological symptoms of dementia, which are the BPSD or neuropsychiatric symptoms, and they are relevant for both diagnosis and treatment. And now we understand this is very well established, but we still don't think so much about the behavioral and psychological elements involved in dementia. What kind of burden we are talking about when we think of neuropsychiatric features in the field of dementia? So the first is that if you have a patient with neuropsychiatric symptoms, the prognosis is worse, unfortunately. There is also evidence regarding a lower life expectancy and a higher level of caregiver burden. And all those three things interact with each other, of course. If you have a patient who is much more difficult to deal with, the quality of care this patient will have is lower, and also this will influence the way this patient can survive and how this patient can deal and can be seen and treated. But it's also important for us clinicians to understand that neuropsychiatric features interfere with cognition as well. So there is an overlap between neuropsychiatric and neuropsychiatry and cognition. So the profile, the cognitive profile we see in our patients is not a pure thing. Actually, the cognitive profile derives and comes from different angles. And if you have a depressed patient, the cognition will be affected and vice versa. And this is important because we use the cognitive profile to think about hypotheses regarding our patient. And we need to understand that this profile may be suffering from interventions brought by the neuropsychiatric profile our patient have. BPSD interfere with different dimensions of the human behavior. So you might have alterations in the emotional experience, you might have alterations in the thought content, in the perception, in the motor function, the sleep, and in the appetite. So all those alterations should be considered by the clinicians and the families regarding the patient. And most of the times, some of those can come earlier than the memory complaint or the reasoning complaint and the cognitive complaint in general. So that's why it's relevant for us to understand that BPSD are a real deal when we are talking about dementia. I want to show this graphic. It's a kind of busy one, but the main message is to understand that despite of this broad and very big range of manifestations, these authors, using the data from the Alzheimer's Disease Neuroimaging Initiative, the ADNI study, they show that the different symptoms of neuropsychiatric aspects are associated in, or better saying, grouped into two big classes of symptoms: the depression and anxiety manifestation, and the agitation and irritability. And what is fascinating about this study is that they saw that even in cognitive normal individuals, they have some neuropsychiatric manifestations. And so we may start asking about patients and their families about manifestations regarding depression and anxiety and agitation and irritability. This will be clues we can use to go and unraveling other manifestations that might be hidden behind. In MCI individuals with mild cognitive impairment, what we see is that there are also two big families, but we have here manifestations more associated with depression and irritability, and we have complex, much more frequent, which means a combination of different neuropsychiatric manifestations. So MCI individuals who don't have affection in their functionality will have a profile of neuropsychiatric manifestation much more often than we think. And in fact, their data, the data from the ADNI study, shows that almost 40% of patients with MCI will have some kind of behavioral manifestation. And these are the data which are more fascinating, I think, and relevant. And again, we are talking about normal individuals here, and those who and how they progress towards dementia. And we see that the level, the pace of progression to dementia in those who don't have any kind of neuropsychiatric symptom is much lower than in those who have some kind of neuropsychiatric manifestation. The profile for agitation and irritability is worse, the expectation is worse. They have a higher rate chance to convert to dementia. But it's not, it is different from those who has depression, but they still have a higher pace. And again, we are talking about cognitive normal individuals. For MCI individuals, things are even more evident and shows how relevant it is for us to understand that behavioral alterations are happening and is a big deal. So again, we see that there is some progression, and we expect this to happen in MCI, obviously because they already have some cognitive impairment, but we can see that there is a difference between those who don't have any neuropsychiatric manifestation and those who have, which progress much faster towards dementia, unfortunately, than those who don't have neuropsychiatric manifestation. When we think about behavioral alterations, it's very easy for us to think about medication, how we can deal with this. We think about pharmacological interventions, but I want to bring this this review, which is kind of older, from 2012. There was a publication this year, 2021, about the same topic, but the idea is the same. We have non-pharmacological interventions available for us, and I believe Sarah Fox will talk about some social prescribing today. And what is interesting is that we have some plans and opportunities of supporting caregivers and changing the environment in order to deal with such manifestations. So the take-home message here is that BPSD play a role in the quality of life for both patients and their carers, and they are associated with early symptoms of dementia and the progression of the disease. And what we are trying to do, and my pilot will cover, is how we should investigate and use translational science to detect BPSD earlier. And it's also worth remembering that any behavior happens within a context, and so environmental interventions might assist and prevent further complications. With that, I want to thank you all for your time and attention and the invitation again. And I am delighted to invite my dear fellow Hanan Khalil, who will talk about her fascinating work regarding interventions in Georgia. Hanan, the floor is yours. Thank you.
Thank you, Luciano. First, thank you so much for allowing me to speak to you today. It's an honor to be here and to talk to you all. I'll be talking about the trajectories in using exercise for brain health and in a brain disease. Just as a background about myself, I'm a physiotherapist who got a degree from Jordan, and then I went to the UK to do a neurological rehabilitation for master and for PhD. So this is the place where I worked for the last 10 years at Jordan University of Science and Technology, which is just located at the northern part of Jordan in a city called Irbid. And just about a month ago, I moved to Qatar University. It's in the Gulf region to do my sabbatical leave. The populations that I work most with is a neurodegenerative populations. I started my PhD working with Huntington's disease, and when I moved back to Jordan, I started to do some work with Parkinson's and multiple sclerosis, and recently just started to do some work with an NGO in Jordan for people or for refugees population. And the three main pillars that we've been working on in these different populations is the use of exercise as an intervention. So I call it, as I'm a physiotherapist, so I would be slightly biased toward this and call exercise as a medicine. But we also wanted to create ways to engage these people with exercise through the technology. And I'll talk about how we used exercise also to manage the non-motor symptoms in these populations. So in Jordan, at least, if I go and do like a sort of survey, why would you exercise? Most of people would link exercise to the physical functioning, to the body, to the loss of weight, to things like diabetes and hypertension. But what we know from a very growing and accumulating evidence that exercise is really very good to our brain. So there is loads of data from studies that has been done in healthy people and in different diseased animal models that show us that our brain does respond to exercise at a structural and physiological level. So at structural level, we see that the neuronal size, the area, the speed of transmission does increase, synaptogenesis and angiogenesis does improve, and at physiological level, exercise does increase the cerebral blood flow, suppress oxidative stress, increase the release of several neurotransmitters, including the dopamine and the serotonin. And the bottom line for this is that with exercise, you have a healthier, more efficient brain that can do more with less effort. So all this has brought the question and the discussion, can then exercise or physical activity act as a neuroprotective tool against neurodegeneration? And I have to say there isn't a definitive answer for this, but we have growing and accumulating evidence from 3 lines of data, from animal studies, from epidemiological studies, and also from registry data, that exercise can decrease the risk of having Parkinson's disease and Alzheimer's disease. And for people who have Parkinson's or Alzheimer, exercise can modify the course of the disease, can make the disease go slower, and can change things at least at the behavioral level. So despite that we know exercise is good for our brain and for our health, and even in neurodegeneration, a lot of people with a neurodegenerative disease would engage in insufficient amount of exercise. So when you look at the reason why there are barriers, and they are different, it could be linked to low self-efficacy, so people are not feeling confident to exercise, low outcome expectations, they don't believe that exercise would be beneficial for them, and there are different sorts of causes and barriers. But when we looked at these, most of them or all of these has been done previously mostly in Western countries, where the context in terms of resources and in terms of culture and factors would be different than what it would be the case in a country like Jordan, with limited resources, with a different culture, with a different environment. So when I went back to Jordan, I just observed that exercise and physical therapy is not part of the routine care for people with the neurodegenerative diseases. And I started the discussion with Dr. Jawad Bajawa, who's a movement disorder specialist, works in Saudi Arabia. And at that time, we didn't have data. So we just wrote our consensus about what we think would be the limiting factors, especially in our countries, of limiting people who have neurodegenerative disease from engaging in exercise. And at that time, we characterized those into personal, social, cultural, and environmental factors. But at the same time, we've been running a number of qualitative studies just to look at what people perceive and what people think. And what we've got that there is limited informational support, so information that it's available about these diseases in general in Arabic language, very, very limited. And it's even more limited when it comes to things like doing exercise and doing physical therapy. And there was also what we call the lack of instrumental support. So usually neurologists, movement disorder specialists wouldn't refer to physical therapy or to an exercise professionals to prescribe exercise for these people. So as an initiative, I started with translating an exercise DVD that goes back into 2013. So DVD, it was used at that time. And this exercise DVD, it was part of what I've done in my PhD. So we developed an exercise DVD for people with movement disorders, but it was in English. So as a start, I translated this exercise DVD into Arabic, and we went into a pilot trial where we evaluated its accessibility and feasibility. difficulty. And what we've got like 8 weeks of home-based exercise program. For this exercise, DVD would produce a moderate effect on most of the mobility and balance outcomes that we used, and most importantly, that people have used it. So the adherence rate was really good. For populations like multiple sclerosis, they are younger, you need more attractive things to engage them in exercise. So as the next step, what we've done, we've built in collaboration with people from the engineering and from the IT, a virtual reality system. We called it Rehab, where we had people to exercise in the form of playing a game, but they will be immersed into it. We also evaluated the potential benefit and the feasibility of performing this, and we got very nice data. So, and we are proceeding in this track using things like the virtual reality to engage people with the neurodegeneration in exercise and in physical therapy. What we are working on now is building a mobile app to online coach people with the neurological disorders, including people with Parkinson's disease and multiple sclerosis, to engage in exercise, because we are realizing that exercise is a behavior. So some people, and particularly when you have on the top a condition, a health condition, and a disabling condition, they need a sort of unique form of coaching. So this is what we are doing now. Now, in all of the work that I've been doing as a physiotherapist, I would be focusing more on the motor aspect. So I did have that bias towards that the main problem would be walking, the main problem would be mobility, the main problem would be physical. But then there was one study where we had handed a questionnaire for the patients, and we asked them using their own language to describe the top 10 areas that they think they affect their life, so their quality of life. And then we asked them, if you have certain amount of money, say for example, $10 US, then where you are going to spend your money to improve, in which of these areas that you named. And the area number one that it came, it's emotional function. So it's things like depression and anxiety, being forgetful, which relates to their cognition. And then things like walking and mobility came second. So the area number one was really is the affective cognitive area. So we started then to think about exploring non-motor symptoms more in these populations that we are working on, and how we can use our tool, our exercise as a tool to improve this or to manage this. So we've done a number of cross-sectional studies. These are examples of what we got and what we know from the data that we've collected. And what was interesting, that there is a great link between the physical symptoms and these cognitive emotional symptoms that these people have. So we found that, for example, depression is a predictor for balance problems. When it comes to fear of falling, it's been linked to cognition and anxiety. Sleep disturbances has been linked to walking difficulties, walking disturbances, motor performance and motor learning linked to fatigue and cognition, and so on. We conducted so far few pilot studies looking at the effect of exercise on non-motor symptoms. So we've done this on sleep, and we have another study that has just finished. The data is still unpublished, where we looked at also cognition. And what we found that exercise, particularly aerobic exercise, does improve these symptoms. And what's most importantly found that it's linked to the improvement in certain biomarkers. And it on sleep, there was also a correlational improvement with things like serotonin. On the study that we've done it on cognition, there was a correlational improvement on BDNF, for example. So this is in terms of the work that we've been doing with the neurodegeneration. And as I said recently, just a few years ago, I've started the work in the area of refugees, just because refugees do resemble a huge amount or a good amount of people who lives in Jordan. We have around 1 million refugees in Jordan, and most of them, they come with a trauma, so they are traumatized. And there is an excellent center in Jordan. It's called the Center of Victims of Torture, who deliver multidisciplinary care for traumatized refugees, and it does include a bath for physical therapy, which is unusual for physical therapists to work in this area. So as academics, we started to help these people just to back up their intervention with evidence-based literature. It's very little that it's found in the literature about the area of physical therapy, movement-based therapies, exercise in traumatized people in general. So we started to explore this with them together. They have the clinical experience, but as academics, we have the evidence-based and the research experience. And within this realm, I've just got supported from the GBHI seed funding to do my biology project, which will be about the development of resources that will help these refugees to do their physical therapy with the CBT remotely. So we will be developing these resources, and we will evaluate the acceptability and the feasibility of these resources with multiple stakeholders in Jordan. So with that, I would like to thank you so much for your attention, and I'm going to hand you over now to Sarah Fox. Sarah Fox is a neuroscientist from the UK, and she is currently work as a public involvement and engagement practitioner. So the floor is yours, Sarah.
Thanks very much, Hanan, and thanks everyone for inviting me here today. You can probably see why I miss these people so much. It's such fascinating work going on all around the world being part of GBHI. So having just graduated from the course, I'm definitely missing sessions with everyone. So let me just quickly share my slides and speak a little bit about some of the work I'm doing at the moment. I have a relatively varied background, so I'm choosing to talk about a smaller part of my work, but I also have a strong background in patient public involvement and neuroscience. But today I'm going to take you through some of the work I'm doing around social prescribing for brain health. Now I'm going to really quickly explain what social prescribing is. I believe that being kind of an Irish audience, you guys are probably going to be aware of this, but just for people who aren't, I'm going to do a little bit of a divergence here and talk about that. So best way of describing it. So the concerns that kind of drive patients to visit doctors. So these are often, I'd say, multifaceted, and a medical treatment might only be part of the puzzle. So that might only be a part of what the patient needs to actually recover from what's wrong with them. And I think this is really important when we're considering health rather than disease. So staying healthy is a different concept from perhaps curing or treating a disease. And this feeds in a lot to what my fellow fellows have been saying about the different ways of approaching conditions and patients. So work like this also relies heavily, I think, on what I'd call patient empowerment. So this is ensuring that people with conditions have an understanding of both their disease, but also what health looks like and what steps can be taken to achieve this healthy lifestyle or this level of health that they want. And I think what's really important as well is that how each of these patients are able to co-create their own path towards what they see as being health, because I think this is never going to be a one size fits all. So, you know, let's consider someone like myself and probably a number of people in the audience where I'm working from home currently. I spend a lot of time sitting at a desk. How many people have told me that, you know, sitting horribly bad for you, you really shouldn't do it, but you've got a grant application in, or you've got something that you're working on and you just end up hours sitting at your desk. So how would someone like me be able to build some changes into our daily activity? What would we do that would work for ourselves? Maybe a lunchtime walk or wake up a little bit earlier to go for a jog. So that's just a little bit of an example of kind of how this might differ from person to person. So social prescribing, I think, aims to approach health in a wider, more holistic way. It's looking at broader solutions to address individuals' health concerns. So this might on the ground look like signposting towards some community support assets, maybe singing groups, maybe exercise groups, maybe knit and natter, so various things, and helping people to understand their condition and to kind of, you know, understand their path to health. Anyway, I've digressed significantly, so I hope I don't go too far over with that, but I just wanted to quickly explain social prescribing for those who didn't know. My background, so I had a PhD from the University of Manchester in neuroscience, where I was an electrophysiologist, so didn't really see many people, did a lot of work with exactly how the brain ticks over and what's going on at the cellular level when you look at dementia and things like this. Recently completed an Atlantic fellowship for extreme brain health, which has been absolutely amazing. And as I said, working with these wonderful people, and there's so much interest coming from across the globe and so many ideas. It's a great melting pot for things like this. I'm currently a project manager at Greater Manchester Health and Social Care Partnership, an organisation called Dementia United. Again, amazing group. We've recently taken control of our health and social care funding. And what we're trying to do is make sure that we're provisioning for people across the entirety of the dementia pathway. So all the way from prevention to treatment to diagnosing and dying well. I'm taking a lead on a number of projects, including Arts for Dementia and Social Prescribing, which is the one I'm going to be giving a little bit more information on here. So people have probably heard a lot of this throughout this conference, so I won't spend too long on this slide. So lots of misconception around dementia still, probably a bit less in some parts of the world, maybe the UK, but people still see dementia as an inevitable consequence of aging. And maybe something that they can't change. What less people know is that these changes that are occurring in the brain are happening many, many years before you're actually seeing any external symptoms or you're experiencing anything that would make you want to go to a doctor. So at these stages, the progression to a dementia isn't inevitable. So I'd say pathology in the brain is necessary but not sufficient to cause Alzheimer's disease. Such interesting work around cognitive reserve, and I wonder if anyone attended, I think Karen was speaking earlier, whether she mentioned Robin Williams, who I think is just such an interesting story about an individual who maybe had quite a lot of pathology within their brain, but their external functioning was very, very good. You know, there was something about his brain that was protective and that was helping him kind of combat what was happening inside the hood, you know what I mean? So there's a lot that we can do to kind of train our brains and to maybe steel ourselves a little bit against what might be happening inside and to hopefully reduce our risk of developing dementia. And I think this is a really positive story because I think when we talk about dementia, people can still feel a little bit helpless. It can be one of those words like cancer, like the big C, but that's because there's so many treatments around cancer now, that's becoming a little bit easier to speak about. But dementia, because we still don't have this cure, I mean, lots of work going on and lots of great stuff, but we're not quite there yet. I think there's still a lot of fear. And I think this narrative around the fact that actually there's so much you can be doing within your own life that could reduce your risk might go some way to allowing us to have more conversations and to allow us to do a little bit more about this. So I think we need to understand risk a little bit better. This needs to be spoken about on a more public level. Having a background in communication and patient-public involvement, I'm really interested in how we communicate risk and the best ways of doing this, because I think if an individual is at high risk of developing dementia, say an individual with a mild cognitive impairment or someone with significant cardiovascular problems, how do we get across that risk without causing fear? Because another colleague of ours who isn't here today, but I think has spoken at this conference, very interesting, the effect of being fearful and how that can actually make life harder for people and actually maybe make it more likely for you to develop dementia because you might withdraw. So fear and risk are very interesting factors to me, but obviously there are things that we can change. And many of you have probably seen this image from the Lancet publications. So things like blood pressure, smoking, staying active, eating healthy, drinking responsibly, keeping on top of existing disorders like diabetes. Sleep's a big one. Undiagnosed sleep apnea could be a problem, and hearing loss. Lots of work going on in Manchester at the moment about kind of encouraging more people to get hearing tests. It's one of those things, I think, a bit like vision, you know, you can go a long time without realizing it's that bad. You may be putting the volume up a bit on your TV, and until someone turns to you and says, goodness, that's loud, you probably don't realize that you're losing your hearing. And obviously Luciano spoke a lot about depression and kind of the chicken and egg element there, but also very interesting. So what can we be doing about all of this, and how can we be kind of encouraging people to increase their brain health and reduce their risk of dementia? So the one thing I want to say is we are in a great place at the moment. So understanding the landscape that's out there, I've spent a lot of time doing this, and I can't say I'm an expert yet. Hopefully I will be. Give me another year or so. But there's a lot of things going on that make this a really great time to be talking about brain health and to be talking about risk and to be helping people manage their personal risk. So we're getting quite good at identifying risk. We're getting a lot of diagnoses. Definitely in some of the localities in Greater Manchester, a lot of people are being diagnosed with mild cognitive impairment. For anyone who doesn't know, this is kind of a cognitive impairment, as it says on the tin, but you haven't reached a stage where you would be diagnosed with dementia. So there's something not quite right for your age, but it's not necessarily a dementia. And without further tests, we often don't know exactly what's causing that. So you can look at kind of cerebrospinal fluid, or you can maybe do some brain scan to see whether there is underlying pathology, but often that doesn't happen. Often there's just this generic MCI diagnosis, and then people are sent back to watch and wait. So this is a great stage to start intervening, because things that happen here might really be able to change your kind of trajectory going forward. Also, here in the UK, we have the Nhs Health Check. So everyone over the age of 40 is offered this free kind of MOT at the doctor. So lots of different tests, and this will pick up cardiovascular problems. And it was also becoming more tailored towards dementia. So I'm really interested in how that can be kind of leveraged, and how individuals who are maybe at higher risk because of their cardiovascular risks might be engaged, and there might be a way to speak to them about dementia as well, and things that can be done. So what's good for the heart is good for the head. Always something good to remember. So much evidence as well. Obviously, we have the Lancet paper here, which is suggesting that risk can be modified, and that this can happen at any stage of your life, and that you can really take control of your health and maybe change your outcomes. Also, if anyone hasn't seen this, I recommend this. I hope you can actually read this, but very recently, Arts for Brain Health Arts for Dementia, sorry, have released a publication, Arts for Brain Health, Social Prescribing. So this is a really interesting read, and there's just so much scope to kind of addressing brain health, but also people living with a dementia, bringing social prescribing into the mix and bringing options as to how to engage more in the community and to access local assets. So I think there's a lot of evidence that this is making a big difference, and it's important. Also, really quickly, there is obviously a global and local impetus for this now. And here I've got the World Health Organization's public response to dementia here. So a lot about prevention here. NICE in the UK as well, and the NHS's long-term plan. We're all looking at downstreaming and just trying to do a little bit more early on. So I think brilliant landscape to start doing things. So fertile soil, what are we doing? Growing a solution. Sorry, silly titles. But what I see here is we've got so many pieces of this jigsaw already in place. So like what Gráinne was speaking about, and Hanan and Luciano, there's so many community assets available. There are so many things available in the community. I've got here in Manchester, we've got the Halle Orchestra, Manchester Camerata, both big orchestras doing so much work in the community around people with cognitive decline. Greater Sports is a sport partnership in Greater Manchester, and they're offering interventions, again, people with cognitive decline, and the Arts for Dementia collection. So how do people find this? I think one of the problems is these assets exist, but it's often quite challenging for individuals to be linked into them or to know that they're occurring. And you hear this from both sides. You'll hear patients coming forward and saying, there's just nothing for me in the community. You know, maybe they go to someone called a dementia advisor and they'll be put towards a dementia cafe, but they may be in an early stage of dementia, or they may have a mild cognitive impairment, and they say, you know what, I don't want to be in a dementia specific group. I want to encourage myself to continue knitting or painting or the sports that I enjoy. But it's harder for them to find community assets who are able to support them. And I think that's where my work kind of comes in. So I'm really keen on creating a platform to allow people living with a dementia or people at risk of developing dementia to access community assets which may help them either reduce their risk or slow down the progression of dementia. And I'm doing that through my work with Greater Manchester Health and Social Care Partnership. Also, as Gráinne mentioned, I am really pleased to have been awarded funding for this project. So again, the same pilot project Gráinne was speaking about, and that's more specifically, I'm going to be sitting within a memory assessments team and working with people with an MCI, a mild cognitive impairment diagnosis, to help tailor our approach to helping them kind of improve their brain health and access community assets. So I'm also really keen to build confidence in community groups. So there might be many groups that are offering singing classes again, or fitness classes, but maybe they don't know a lot about dementia and cognitive impairment, and just with a little bit of confidence building and a little bit of training, they might be able to open their doors to a wider selection of people and really help. So excited for the future, but there's a lot to do. And as you can probably tell by my waffle, I'm still in very early stages of all of this work. Final thoughts, I want to leave you with a really nice little quote back from 2010, actually, from the National Dementia Declaration for England, which is, people with dementia want to live in communities that give them choice and control over their lives, provide services and support designed around their needs, and to feel valued and understood, part of family, community and civic life. And I think this is what social prescribing is offering. So I think when we link the two together, we're going to be moving in a really great direction. Also, I said that was final. This is final. So I have a question for everyone, really. You might have questions for me, but I have a question for you. There's a load of evidence and assets, I think, in place for people living with dementia to benefit from non-medical interventions. But why do we think they're not accessed regularly? So like I said, I have individuals with a diagnosis come to me saying there's nothing available, I don't know how to access this. But I also have community groups providing these services coming to me saying, no one's coming to our groups, how do I advertise this? What are the barriers? Why are these people not being connected? And how do we think we can solve that? And if you can solve that, then you've done my work for me. But anyway, that is me. Thank you very much. I will hand back to Karen and we'll start the Q&A. So thank you, everyone.
Thanks so much, Sarah. And thank you, everybody. I miss you all so much. Now, to the people who are participating in this wonderful Engaging Dementia conference, guys, I'll request you to all stick on your cameras and let's have a look at you. You'll see how we get so excited about people in GBHI and the work that everyone is doing. It's an eclectic, mad bunch of people who are so clever, and most of them are clever in a second and third language, which leaves me amazed that Luciano and Hanan, who can speak several languages, and you know, I love their company, and it's great that we're all back here again today. I've invited Francesca to come and invite us on the panel again. Francesca is also our colleague in GBHI. Kevin Quaid, I'm delighted to welcome you back as well. I know you've done some work with Sarah as part of PPV. So to kick off one of the questions, we have lots of time now. Tomás unfortunately had to leave us. He had that hour difference in Chile. So there are a couple of questions that are in the chat box, so I'm going to ask them. So I'm going to start from the bottom and work backwards. So Carol, you have a question here, maybe a database in each area listing available resources and local libraries. I think that question is for you, Sarah. Maybe do you want to go back to that?
Yeah.
What are the barriers?
And that is exactly what we need. And I think for me, it's how to maintain those databases as well. From Greater Manchester, we have great examples and we have poor examples. So there are certain localities where someone from the kind of governance side of the locality will run a database that has everything on there, such amazing activities, and anyone can access it. We have other localities where I'm working with social prescribers who are sitting there very, very busy from their day job whilst also trying to maintain their own databases and not exactly being able to. So I think from a kind of policy level, we need to be looking at having individuals in place to maintain this where that is their job, because obviously things change very quickly and these things need to be kept updated. But I think a database is one of the best ways forward. But I think for me, it's kind of who owns that, who maintains it and who manages it. And it sounds like it's an annoying thing to have to worry about, isn't it, who maintains it? Because I would just love to maintain it myself. And I keep wanting with the Dementia United, oh, can we do it? But everyone is very busy, and if it's not maintained properly, it's not terribly useful. So it's just having the structures in place to make sure that's maintained. But my basic answer is yes, we need a proper database.
Yeah, and I would agree. And Sarah, it comes back to something we spoke about earlier when we were chatting earlier about Lewy body disease. Twitter is a great source of information. I know a lot of people hate social media, and I used to be one of those people. I'm not anymore. I'm a convert, you know, and you can be as involved or not involved as you want. But on Twitter, you get to read the most amazing journals, the most amazing articles. I suppose it was really when I became involved in GBHI and I realized that the world is a very big place. And there are so many people who know so much stuff. And many of them are here on the panel here today. So I'm working backwards. Engaging Dementia had a comment there. This is a fantastic, holistic, all-inclusive approach to dealing with dementia and brain health and well-being. The work that all the panelists have done and continue to do in the Global Brain Health Institute is awe-inspiring. I totally agree. The guys in the GBHI community are phenomenal. And it's like Hotel California, you know, once you are a GBHI fellow, you then become a senior GBHI fellow, and then there you stay forever. So if you want to join GBHI, you would be most welcome to join us. Unfortunately, the 2020 September application process has already been complete, but if you fancy doing this, you can join us in September 2023. So go on to gbhi.org, and if you want to go on to all of the profiles of our panelists here today, you'll be able to see a whole profile about them and learn a little bit more. And what you might enjoy is the bit that I enjoyed hugely during the last year is a podcast, a radio podcast. I have had the great pleasure of interviewing each and every one of these amazing people here today. And they'll tell you a little bit more about themselves and their work, and also favorite songs, favorite poems too, which is lovely. So we also have another question here from Frances. Yes, she says, it's great to hear what's happening around the world and to know that GBHI provides such a forum for information sharing. You're absolutely right, Frances. There is huge work being done all around the world. So engaging dementia, yes, Fiona asked the question, would the PowerPoint presentations be available at a later date? They're all on video. This is being recorded. You can watch it back at your leisure and you can see all of the slides and go through all of that again. Now we've one for you, Gráinne. Could Gráinne consider a pilot music project in nursing homes in Dublin? And if so, could you share your contact details? Quite a hit, Gráinne.
Of course, this is an area, as you can imagine, I'm passionate about. So we are always delighted to see more people interested in bringing music in, appropriate and sensitive place music into settings. So by all means, there's some way we'll share after this my details. Actually, you could probably get them on the GBHI website under my profile. If anyone would like to contact me further, I will certainly after the pilot find a way to share the results of the pilot with everybody further and the work that I'm continually doing. But I'm all ears and open to any opportunity there is to share music with any one person, 100 people, whatever it is, it doesn't matter.
Fantastic, thanks, Gráinne. And if you want to contact any one of us, it's just put a full stop between our first name and our second name and at gbhi.org. So that's gráinne.hope@gbhi.org, or hanan.khalil, or sarah.fox, or luciano.mariano, and francesca.frina. Now, Francesca unfortunately can't join the panel now, but if you have any questions for her, please direct them francesca.frina@gbhi.org. So I'm still working backwards. So we have Carol. Thank you, Gráinne. Certainly looking forward to seeing the outcomes of your pilot. Yes, me too. I definitely agree that the arts are a fundamental part of engaging with people with dementia. Totally couldn't agree with you more, Carol. Kathy McCarthy, excellent, Gráinne. Thank you for sharing. Music is the key to the soul and can establish a true, pure connection when supporting somebody living with dementia right through their trajectory. Yes, and there's one new message I can see coming in at the very end there. And this is from yes, this is Dr. Sarah Fox back again. They missed the commenting on libraries. Great idea. Worked with libraries before. Amazingly supportive and helpful and well connected to the community. Now, speaking of community, I would like to invite back in Kevin Quaid. Kevin, you're very well connected in your community and you've worked with Sarah Fox. Tell us a little bit about the PPV project from your experience.
The thing I like about these projects is they're no longer a box ticking exercise. It's no longer that we need to get a person with dementia, we need to get a carer, with them done. They're at one side and we'll continue on with our project. And that was the case up to a couple of years ago, but now we kind of become central figures all of a sudden. And to me, it's amazing. And a funny story, I did my first research project. I was doing it with a professor in Limerick. I won't name and shame him now because he's not here, but he was terrified to meet me because he said, how am I going to talk to this man? And I'm thinking, how in the name of God am I going to be of any use to a professor in a university? And like, it was Dr. Laura Philbean who put me in touch with him, and I trusted Laura, and that trust had built up because of research. And within an hour of talking to Andrew, you probably know who he is, I was made co-lead in the paper. And that just makes us, it makes us feel worthwhile. It makes us feel that our contributions are valued, but it makes our voice important. And I think it makes our voice important for ourselves, for the researcher, and for the end result, if that makes sense. Like, everyone benefits out of it. I benefit out of it, the researcher benefits out of it, and hopefully the end result will benefit out of it. The one thing that I kind of have not too, I suppose I won't say not too happy about, but I hear research being done just for the sake of research being done, and there's the research paper, we'll put it into the file and file it away on the job done. No, it needs to be built upon and built upon and built upon. And I think, Sarah, we might have even had this conversation that, you know, if you're looking for new research, look at research that's done already and see can we expand upon it, see can we work on it, you know, dust down the old files and see what's there and work on the ideas. In other words, build on the shoulders of those that have gone before us. And I go back again, I spoke about him earlier, to Ken's dad, Dave, who's in the nursing home, who has gone from being, as Ken said, almost being sedated, to where he can now play 45 because he's been diagnosed and medicated properly. We need to build on the shoulders of those people, and I think that is so important. But to involve us, it makes us feel important, and who doesn't want to be made feel important, you know? And the people that I've worked with so far, Sarah and so many more, it is it's what keeps us going, it's what keeps us alive, and it's what keeps us at home, and a smile on our face.
So important, Kevin, because nothing about us without us, and that's what Gráinne's put in the chat box. And I think when you meet anyone from GBHI, there is an ethos there, and there are a set of values that I'd love to share with you. It's called AFORCE. So A is for authenticity. And I think what you found today is, listening to all of our speakers here today, an authentic voice, the work that everyone is doing, they're doing it, they believe in it. It's that whole thing of, you know, just before the break, before the lunchtime break, what can we do to help people with Lewy body disease? Believe, and that's authenticity. F is for fairness and equity. It's another name, equality, fairness. You know, do we treat everybody the same? People who maybe haven't had an opportunity, as we all have had in the last year, to have this amazing fellowship, you know, to share the information with other people. Kevin, you know, the whole thing about being on a paper, that's an amazing thing, to be on a research paper, to share that information. F is for fairness. A force, O is for openness, and openness is what you've heard from, I can see Dave is, Ken, Gráinne is still with us, his dad Dave, the openness with which Ken shares a story, Helena shares a story, and Kevin shares their story. We're never going to learn unless we're open with each other, and that's what openness is all about. R is respect for everybody's point of view, no matter where they live in the world, and at what station they're at. So that's respect. E is equality, empathy, equity. I like to think equity is a word that we use all the time in GBHI for the year. And T, R-E-S-P-E-C, yes, C is a funny one. C is for courage. But Gráinne and I fought the good fight all year, saying it's not just for courage, it's for creativity, for community, for commitment. for colleagues, C is a huge word, and that's the one we like the most. Yeah, it's for courage, but it's for all those things as well, especially for creativity. And RESPECT, T is a force. Oh, where am I going? I was thinking of Aretha Franklin. RESPECT, it's kind of the same thing. So a force. And there is one other one that I would like to include in this, and you've got a world premiere on this, is I would like to include in A for the silent H, to throw in humility, humbleness, honesty. These are all the things that and humor. We need to include humor in the work that we do. We need to understand, we need to break it down into the smallest parts so that we can all understand. So with that, I'm going to introduce one of the funniest guys that I've met this year. Luciano, you have a question for Hanan.
Thank you, Karen. I don't know if I am. If I am one of the funniest guys you've ever met, I'm very sorry for you. So, but I have a question for Hanan. Please, Hanan, I was fascinated by your mobile app for self-management for patients with Parkinson's disease. And I was wondering if you could expand a little bit about this experience, and if you had the chance of working with patients with Alzheimer's disease also using this platform, because the management is completely different, I believe, considering some cognitive limitations and how this went.
Yeah, well, thank you, Luciano, for the question. So we are at the development stage for it. So and for that, we are involving people somehow. So we are working towards what features need to go there, how we can present it to them, and how physiotherapists can use it to support people. We thought we will start it with Parkinson's and MS, because these are the most populations that we work with and we have accessibility to them. But it will be based, part of it will be based on a program that has been done on Huntington's disease before, and it's called Engage Huntington. So Engage Huntington, it's a coaching program that was done like by one-to-one. So the physio has to visit the patient and they do the coaching session at home. This is making an online version of it. And when it's online, sometimes there are difficulties that you need to manage. So at the moment, we are working on characterizing the features, what it needs to be there to make it doable, to make it visible, to make it applicable to those. I haven't thought about dementia, but definitely it's something that it's on the way. We need first to try it with the populations that we started to work on. And I think the future that it can goes into many populations who have like similar problems, physical and cognitive as well.
Thanks, Hanan. And I can see, Kevin, you've got your hand up there.
Index shows are resting against my cheek. But to come back to something that was asked earlier on, how can you help inside the nursing homes or care home facilities? And it was something that Ken and myself spoke about the other night. And now that his dad is improving, I asked him what were the tremors in his hand. And he said they were gone. I said, did he like jigsaws? He said, yeah, he did. So I said, why don't we out a jigsaw, maybe for a 6-year-old or a 10-year-old? And if he throws it at you and says, you know, how stupid do you think I am? Well, then bring him out a 100-piece jigsaw, and a 200-piece jigsaw, and a 500, and increase, and increase, and increase, and increase, and increase. Because just because we're not fit to be at home anymore, I have REM sleep behavior disorder. Part of my Lewy body dementia is violence, and I've never been a violent man, and I have never in my life, I've always believed a man doesn't hit a woman. End of story. There is no conversation around that. That's the way it is. But should the day come that I would raise my hand in anger to Helena, let it be Louis that's doing it. I don't care who you call it. The actions are taken by Kevin. Then I have to go to a facility, a care home facility. That doesn't mean that the rest of my life has to stop. It's still or ever the rest of your life has to be improved upon, because there will be a grieving process by Helena, by the kids, by me and everything. So when you get to that place, it's still or ever, I think you should really look at like hobbies, like Ken had said, about playing cards, doing jigsaws or whatever, and build upon that, build upon it, build upon it. Again, as I've said 1,000 times, it's standing on the shoulders of the people who've gone before us. I better be careful what buttons I press here in the future.
Thanks, Kevin. And, you know, that's one of the things I really love about you, is your honesty. And it's very refreshing to hear it. And I think when you speak as honestly and as openly as you do, you encourage other people to do it too. So you're quite a beacon.
Well, look, Hanan, you spoke earlier. I missed it because I'm blaming Khalil and my dinner was late. You spoke about Robin Williams, and we all know the way Robin went. For everyone that's on here today, that is nothing new with Lewy body dementia, because I tried to commit suicide in the early days, and I would have been gone, but for the fact that I'm a cheap bugger. I buy my belts at Dunn's, and they don't hold the weight of a 20-stone man. I was off the coffee table. I probably hung for 2 or 3 seconds, and the belt broke. And you know, you have to see the humorous side of it now. For Helena, it wasn't, but I've walked so many mornings and I have said, but for the fact that I know what's wrong with me, I wouldn't stay here. I couldn't cope. I couldn't cope with living. So again, it comes back to proper diagnosis, proper care, proper treatment, proper medication and non-medication. You know, like if we can get that combination right with everything, we can put a smile on our faces. And isn't that how everyone wants to be able to smile and be happy? And it's not doom and doom all the time. Like, I'm great crack when I have a few pints. There was a video online of me the other night singing a song in a pub, and I'm not supposed to be seen.
Kevin, I heard you the following morning, you were hoarse as a crow. And for the people who are with us, I know, Gráinne, you have your hand up, I'm going to ask you now in just a sec, but for the people who are with us, there is a new thing that is, you might have met Irasima Leroy, for those who are joining us for Lewy Body Ireland, which exactly was my pilot project for GBHI. And I want to say thank you to GBHI, I got funded for that as well, so thank you for that. Irasima has got some funding from Europe for this thing called Dementia Trials Ireland, DTI, which is starting at Trinity College in November, along with Professor Sean Kennelly in Tala Hospital. And the whole point of DTI is that there are pharma and non-pharma treatments. And this is what we're going to be doing over the next 5 years. I've the good luck to be working with Irasima for the next couple of years, 2 days a week in Trinity. So that's going to be my job, as well as working with Lewy Body Ireland. So if anyone on the panel is interested, or they think they might know somebody who's interested, and by pharma and non-pharma, I mean, if somebody would like to join an art class or a dance class for Parkinson's, I know that's something that Hanan, when we spoke on the radio, exercise is good fun, but dancing is way more fun. So if it is that you have Parkinson's and you want to find a way to, you know, make sure that the left side of your body is working as well as the right side of your body, you know, join a dance class. You know, music, Gráinne is our expert on music. These are all non-pharmacological treatments that we can use in the care for people who have dementia and their family members as well. So, you know, by all means, contact me if you have any questions about Lewy Body Ireland, but also if you have anything that you want to contribute to dementia trials. It doesn't just mean scary drugs, of course it doesn't. It means if you want to be a participant in a survey or in a journal or anything at all like that, you'd be very welcome. Now, Gráinne, you had your hand up, go for it.
No problem at all. It was just to add to a little bit of what Kevin was talking about in relation to nursing homes, you know, and somebody's life and quality of life. You know, they may need to be there because of the care they need, but it's also about choice. And, you know, you hear wonderful things, oh, music isn't the answer for everybody. But what I would say is to offer the choice at all times. And whether it's someone needs support from their carers in the environment who may know them a bit better, if verbally, it might be challenging for them to answer. And that's one thing that I know with my work in this and training of musicians, the more knowledge you have, anyone has in any area, the better you can be at what you're doing. And as artists and musicians bringing music and sort of into the care environment and into the community, the more we know about dementia and people and how to offer the choice and how to appropriately share music. And it is about, there's so much evidence there about, it's not my music, it's their music. So our projects that we go in, it's all about offering choice. And I know Sarah mentioned the 2 risks there, and you mentioned it, Karen, in relation to some of the studies about vision and hearing loss. And part of that is, you know, if we pipe music in on headphones or on the TV in the background, it can be very challenging for somebody with cognitive impairment to differentiate what that is. And if you're just bringing music and live music in, you're just adding noise, which can be more harmful and add more behavioral challenges for the setting. So it really is key for anyone interested in bringing in live music, and there's plenty of evidence there, the benefits, and other art forms as well. I advocate for all the arts, but being the musician, I have direct experience with that, and it is key that everybody in the setting understands the purpose of the music and how we can help share the music for that person, their song, their tune. If it's online, if it may need Bluetooth speaker, that'll help. It'll put the sound a little bit higher beside somebody so they hear the sound closer to them. It may mean reading instead of iPad. It might be very challenging to understand that a big screen, you know, there's many things that can be done. So I would just advocate to anyone listening in here who has a setting or is interested in engaging in the arts, really partner with, you know, with an organization or someone with experience, so that it truly is accessible and it has an equity of access for everybody, and it's their choice. And yeah, it was just to share that I think my whole journey started in this. I felt like if for whatever reason in life, through economic, social, or medical circumstances, you couldn't access music and you're a real lover of music, you should have the choice to access it regardless of location. And that brought me to bring music off a concert stage and into communities, whether that is at a community centre for a tea and tune session for an Alzheimer's cafe, or whether it is in a nursing home for everybody there. So I just encourage everybody to look at the options and the role that arts might be able to do to help people in our community today. And I know I've talked with Kevin before about he has a playlist on. We've told a wonderful story. It's your story, Kevin, so I might pass it over to you to share. But about, you know, your YouTube link, and you can just click on the button when you need it.
Yeah, and the funny thing about it is, and you made a very important point, there is a class in I know because I'm a care bright now, because I'm in several different places singing for the brain. It happens during the day. As a person with Lewy body dementia, I couldn't think of anything worse to attend. I just couldn't possibly think of anything worse to attend. I absolutely hated the idea of it. This is from a man that was a DJ. But I'd wake at night after a horrific nightmare or something, and I'd put on YouTube, and there's a playlist of all the songs that I used to play when I was a DJ and that. And that's what keeps me from breaking down, from crying. It brings me back to reality. It takes me to my happy place. And it's the same. I watched The Big Bang Theory over and over again, and I never really understood what arts had to do with any of that, with dementia in any way, until Karen explained it to me. And you'll see behind Karen there that beautiful drawing that Connell did of me and of Robin Williams and that. And I just went, oh my God, how did I miss that? And I'm at this for so long. And come back to the Dementia Trials Ireland. When they went for their grant, they didn't do a box ticking exercise. They took me with them to speak. So anyone that's looking for a grant for researchers, it might be not harm to take one of us with you. But yeah, and listen to the person. And I don't care how advanced they are. I don't care how far their dementia is advanced. If they have a voice, do you like music? Yes or no? Do you like cards? Yes or no? Do you like dancing? Yes or no? Listen to them. They'll tell you. They'll tell you. It's as simple as that. You know, we don't have to invent the wheel here in an awful lot of things. It's the small, simple little thing that makes our life so simple. And that's what makes people like you guys come, every one of you, Sarah, Gráinne, every one of you. She keep me alive, and she keep me at home. She keep me happy. You know, after today, I want to go out and celebrate this evening. But at least that's my excuse.
I think that's somebody inviting you, Kevin.
Oh,
Now we're almost at a close. And I'm so glad, Kevin, that you mentioned Kunle Adewale, who is a senior GBHI fellow. This is Kunle. He is from Nigeria, and he's an artist, and he is the guy who drew this amazing picture of Kevin. He also drew the picture of Robin Williams that's on the back of the book there. It's about, and in Nigeria, in Lagos, his work is about getting people, he was a street child himself, so getting people to express themselves through the arts. And I suppose if you're working in a care home, as Gráinne was saying, find the thing that the person is interested in. Not everyone, I'm in the forget-me-nots and I love it, but it's not for everybody. You know, find what it is that they want and then give it to them. It's like the old-fashioned thing of marketing is, you know, how do you do some marketing? You find out what somebody wants and you give it to them. So if you're working in a care home and if you've somebody who maybe you can't connect with them for whatever reason, maybe you just haven't found what the connection point is. I know in one care home, there was a retired accountant and she loved nothing more than to go through all the bills for the care home and she matched them and she went through the job and that was her job and she loved it and she saved them all a nightmare, you know, and that was what she wanted to do. And there was another person who worked in a hotel all their life. They wanted to be in reception and they let them off. You know, you're in reception and they greeted every single person as they came in. So all you do is you just find out a little bit about them, ask a few questions. What did you do? What did you like to do when you were young or your first job? And that's where people who, like my mother had Alzheimer's, so she couldn't really remember a whole lot of what was going on recently, but in her past, she was able to tell you how much she loved poetry and how much she could recite poetry at the drop of a hat. So, you know, so these are all the things I suppose we want to share with you is, you know, all the skills that we've learned and shared from each other and with each other over the last year. I suppose for GBHI, we could talk for the next 2 hours about the work all our colleagues are doing. Visit us on gbhi.org. You can see all the profiles of the people here. I just want to say, as we're wrapping up, to have a huge thank you to Francesca Farina, who you heard earlier in the session talking about fear and fear of dementia and fear in general. You can catch her on francesca.farina@gbhi.org. To my lovely colleague Gráinne Hope, gráinne.hope@gbhi.org. To Luciano from Brazil, Luciano.Mariano at GBHI. Great dancer, by the way. If you need a choreographer, you've got Luciano. Hanan.Khalil@gbhi.org. Thank you so much, Hanan, for all the work you do, in particular for the refugees in Syria. And for Sarah Fox, thank you so much, Sarah.Fox@gbhi.org. And for Tomás León, who had to run away, he had patients, Tomás.León@gbhi. I also want to thank you again, Kevin. You stole the limelight one more time. Thank you all. And a final thank you to Kim, to Manuela, to all of the group in Engaging Dementia. Thank you so much for giving GBHI this forum, this platform to talk about our work. Thank you so much, Kim, for the second time in as many hours. Thank you.
Thanks to you as well, Karen, for helping us pull it all together, getting everybody organized, and for, you know, leading the panel discussion today. It was a lovely discussion, full of energy and really nice things that are happening around the world. So great way to end our conference today.